Okay, so I'll go ahead and get started. Welcome everyone to our session on understanding quality improvement with a health equity lens. Really glad to have everyone here today. I'll start just by introducing those of us you'll be hearing from today. My name's Ann Smithy. I'm a senior program officer at the Center for Healthcare Strategies. I'm joined by Vicki Quintana, another senior program officer at CHCS, and we're really happy to be working on this and be funded for this by Amber Johnson and Katie Breen at the Colorado Perinatal Care Quality Collaborative. So thanks so much, everyone, for being here today, and the four of us, we're your presenters and your hosts. We'll start today with welcome and introductions. We'll do a little bit of a data review, understanding sort of the state of maternity care in Colorado. And then we'll dive into what an equity lens means in the quality improvement setting, tools you can use to do quality improvement with an equity lens, including a root cause analysis tool and some additional tools. We'll save some time for Q&A and we'll wrap up. So for those of you who don't know us, the Center for Healthcare Strategies is a national nonprofit dedicated to strengthening the U.S. healthcare system to ensure better, more equitable outcomes, and in particular, we focus on people served by Medicaid. So together with our partners, we work to advance effective models for prevention and care delivery, efficient solutions for policies and programs, and equitable outcomes for people facing the greatest needs and health disparities. So for today, as a reminder, this is a Zoom meeting, not like a formal webinar, so please do mute yourself when you're not speaking to reduce background noise. You can rename yourself if you'd like to tell us where you're calling in from today. And we want this to be an interactive learning session, so we welcome your questions, thoughts, and contributions. You can post in the chat, we'll be monitoring that, or you can use the raise hand feature and come off mute at any point with questions or thoughts. We'll also have some interactive portions throughout, so looking forward to hearing your voices during that time. And at the end, we'll share a link to complete a brief evaluation survey. We really appreciate hearing your feedback on how we did today. So as some of you may know, this is the second in a three-part learning series. Last month, we presented on opportunities to improve race and ethnicity data collection. Today, we'll talk a little bit about how to use that data, doing quality improvement with a health equity lens. And about a month from now, we'll talk about communicating about health equity work and data collection. If you have only registered for today and you'd like to join us next month, you can scan the QR code on your screen to register for the next session. And so just to place us in the series once again, as I mentioned last time, we talked a lot about promising practices for collecting REL data, about understanding the role of racism in creating health disparities and how collecting and analyzing individual REL data can help to identify disparities. We talked about training for staff who collect data, including explaining why they're asking for this kind of information from the patients they're seeing. And broadly, we talked about that collecting REL data is a way to begin a conversation about improving the care experience and improving care delivery. So now we're thinking about, okay, so we've worked to improve REL data, we've got scripts, we've got champions, we're starting to have that information about our patients. What do we do with it? And one of the next steps there is to think about the quality improvement activities you all are probably fairly familiar with, but doing quality improvement with a health equity lens. And we're focusing on that because using an equity lens can lead to the design of workflows and improvement activities that reduce health disparities. And it can enhance accountability and sustainability by embedding health equity thinking and practices into new processes, but also into existing QI processes that you may already use in your day-to-day work. So today we hope you learn about these quality improvement activities and tools and really kind of figure out what a health equity lens means and how you can use individual patient demographic data to get started with sort of a new or maybe an updated form of quality improvement work. So to get started, I'm going to share a little bit of foundational information that I think will be helpful. I'm reviewing some data on maternity care in Colorado. So at a total population level, you may all be pretty aware that maternity care and birth outcomes in Colorado tend to be pretty good. The Commonwealth Fund did a state scorecard on women's health and reproductive care last year that showed Colorado was ranked 15 out of 51 states, or I guess 50 states in Washington, D.C., on women's health and reproductive care outcomes. Your rates of maternal death are lower than the national average. Your rates of C-sections for first births are lower than the national average. So these numbers look good. They're promising and they're exciting. But one thing that we know to be true is that overall high performance can sometimes unintentionally mask worse outcomes for specific subpopulations. So this overarchingly good performance doesn't necessarily show how we're doing for every specific group of patients that we're taking care of in Colorado. And that's why using individual level demographic data, like the race, ethnicity, and language data we talked about in our last session, can be really valuable because it can help us stratify outcomes data and uncover disparities that are experienced by the patients we're serving. So on the next few slides, I'm just going to share what some of those disparities look like at the statewide level across the state of Colorado. And before I get into exactly what these slides look like, I did want to note that we talked a little bit last time about data visualization and presentation. And I just wanted to say, the data we're presenting today may not always follow the best practices we discussed last time. We're using data from a variety of sources, which means the data might not always be self-reported. It might not always be looking at OMB standards, the kind of like race and ethnicity data standards we talked about in our last webinar. And I think this is reflective of real life, right? We have to work with the data we have. We can't let perfect data be the enemy of moving forward, seeing what disparities we can find with what we know. But I am going to do my best to present the data to you in the way that is mindful and reflects these best practices. And one thing that's really important anytime we talk about racial disparities or break data down by race is emphasizing that we're not looking at the impacts of race on outcomes, but rather the impacts of racism. There's nothing inherent in a biology or physiology of a particular race that leads to worse maternal health outcomes or poor infant health outcomes, but rather the impacts of racism and unequal systems and unequal healthcare. So on this first slide, we're looking at low-risk cesarean births by race in Colorado. You can see from this data that Black patients and Asian and Pacific Islander people in Colorado are more likely to experience C-sections during low-risk births than white people or American Indian and Alaskan Native people. So that's one of the disparities we can see in maternity-related care in Colorado. On this slide, we see preterm birth rates. Rates of preterm birth vary quite a bit across maternal race and ethnicity. I've added in the state average in that red arrow, which would sit between the number for Asian people and Hispanic people. And we can see that this data, which comes from the March of Dimes report card for Colorado, really emphasizes that Pacific Islander people in Colorado are the ones who are experiencing the highest rates of preterm birth over the last handful of years. And then we can also see this data from the Colorado Department of Public Health and the Environment's vital statistics, which shows that infant mortality varies substantially by race and ethnicity, with higher rates among infants identified as Black, multiracial, or Hispanic, as you can see from this graph. Also, we compare it to the statewide average and see the subpopulations who are experiencing higher rates of infant mortality versus those who are experiencing lower rates of infant mortality, really emphasizing where there is more and less advantage and disadvantage in our society and in our healthcare system. And the last piece of data I want to emphasize for you when we're thinking about why we need to bring a health equity lens to quality improvement and why we should be looking at disparities and not overall performance is addressing negative experiences of care. Sometimes it can be really hard to look at these broad outcome measures like infant mortality, preterm birth, that we know are impacted not only by the care a person's receiving at a hospital or birthing center when they're giving birth, but that also reflect preconception care, prenatal care, and in some cases, postpartum care. But what we do know to be true is that negative experiences of care or positive experiences of care are really impactable in that moment that a person is in the hospital or birthing center, presenting in labor and giving birth. And we also know that unfortunately, mistreatment while receiving maternity care is fairly common. The CDC has done some studies showing that nationally about 20% of women reported mistreatment while receiving maternity care. and that number was higher for women of care. The same survey showed that 1 in 3 Black, Hispanic, and multiracial women reported mistreatment through maternity care. And mistreatment can be broad. It can look like a lot of different things, including not receiving a response when you request help, being shouted at or scolded, not having physical privacy protected, or being threatened with withholding treatment or made to accept unwanted treatment. So as we look at outcomes data and we also look at experience of care data, we can see a lot of different opportunities to apply this equity lens and a quality improvement process that we've been discussing. And I also just wanted to take a few minutes while we're on experience of care to talk about some current and upcoming work going on in Colorado. So the legislation in Colorado has worked to make experience of care through maternity care more front and center to healthcare providers and regulators. Your Civil Rights Division must accept complaints about mistreatment during pregnancy and postpartum. Hospitals and other birthing facilities have to allow people to bring in a support person or doula, which can help people, can protect people against negative experience of care. And the State Maternal Mortality Review Committee has to start thinking about ways to collect more data on marginalized groups, and that has to include mistreatment people experience. So there's a real push in Colorado to start exploring tracking and measuring negative experiences of care. And that's something that's happening at the legislative level, but is also starting to happen more in hospital and birthing centers in their quality improvement efforts. And we can really start to think of experience of care through patient-reported experience measures, or PREMs. I've shared one here created by Dr. Karen Scott, which focuses exclusively on the experiences of Black people and racism during childbirth. But I'm also going to take a moment on the next slide to explore some of the things CPCQC is doing. So CPCQC is working on exploring a survey as a component of the Spark Postpartum Discharge Initiative that can be a way to continue focusing on experience of care in QI efforts in Colorado. This would be an anonymous survey, a brief survey provided for birthing people to share feedback on their experience during labor and delivery. And questions around experience of care, there's some examples on this slide, like whether a person felt that their choices were respected by the care team, that the care team understood their background, home life, health history, the care team communicated well with them, did a good job listening to them, and asked for permission before carrying out exams and treatments. So all things that make a lot of sense and are really valuable to the patient, and data that can be really helpful in a care setting to explore where we can change processes to provide a better experience of care to all of our patients. So I'm going to share one last slide on additional examples of places that are addressing negative experience of care in case this is something that's piqued your interest. California's Maternal Quality Care Collaborative has been working on developing a hospital action guide for respectful and equity-centered obstetric care, a survey for hospitals, and a series of free webinars focused on creating a respectful care environment. Illinois' Perinatal Quality Collaborative has developed respectful care commitments, which include introducing the care team and their roles, learning a patient's goals for delivery and postpartum, practicing active listening and valuing personal boundaries, and a handful of other things that can be really helpful principles. And then Denver Health has started to put into place a process called an equity check that they use after adverse events have occurred, which asks if any social drivers of healthcare were present, including bias, either on the provider side or the patient side, and if those drivers had a role in the negative outcome of the case, really trying to get a sense of what things outside of maybe what we typically measure in quality improvement work might affect experience of care or patient outcomes. So I hope with that section, I gave you a sense of both why it's important to start thinking about equity and disparities in QI work, and some of the measures, both process-wise, outcome-wise, and experience-wise, we can start thinking about for improving equitable care, equitable maternity care with our QI efforts. And so now I want to take a moment to start thinking about aspects of an equity lens. And I realized there were some polls we were going to do earlier that I totally breezed through, so I'm just going to skip those. We'll have interaction in the next section. So when we think about aspects of an equity lens, I think it's really important to think about kind of two elements that can shift your QI efforts from maybe what you've been doing, which focus on the general population, to efforts that focus more explicitly on equity in care and outcomes. The first one is shifting how we frame problems from an individual lens to a systems lens. So when we think back to the C-section data we looked at, we might typically frame a question around inequities as something like, why do Black people have more C-sections than white people in the data we looked at? But that can unintentionally blame the patient for the negative outcome, right? We're subtly framing it to think about the experience of care Black people are having and what it looks like for them. Instead, intentionally bringing in an equity lens can force us to refocus the issue as sitting at the system or healthcare level rather than the patient's level. So instead of asking, why does this group look different than that group? We might say, why does our hospital perform more C-sections on Black patients compared to white patients? Situating sort of the issue we're seeing in the outcome at the system level. It's also really valuable to frame things at a systems level when we're thinking about providers. Through the patient safety movement and preventable errors in healthcare, the healthcare system really learned that individual blame is not helpful for fixing problems. We know that healthcare providers aren't trying to provide disparate care. They're doing the best they can. You all are going in every day, taking care of your patients to the best of your abilities. But everyone's influenced by the systems and the structures that they work within. And if the systems and structures are biased, sometimes the care will be too. So framing issues of inequity at the systems level reduces the risk of blaming individual practitioners unfairly for disparities. Again, situating this at a level of system that we all must fix, not you must fix. And so framing at a systems level is more fair and places the problem at the correct and solvable level, both for the patient and for the provider. So I want to take a minute to practice and think through how we can frame a couple of different data disparities that we see in the data at the systems level. So first you see a graph showing disparate preterm birth rates by race. In typical sort of framing, individual focused framing, we might ask, why do Pacific Islander patients have higher rates of preterm birth? So I want to ask you all to use the chat or come off mute if you'd like to share a more systems-focused frame for this data, avoiding both individual blame for the patient and for the provider. If you'd rather, you can also do that for this data on patients reporting mistreatment while receiving maternity care. So again, shifting from individual focus to systems level focus. So I'll give people a moment. Feel free to share in the chat. Feel free to come off mute. If you'd like to send it in the chat just to me, I can share with the group if you don't want to share with everyone. All right. I'm going to give everyone another moment, but I'm also going to tee Vicky up if you don't mind sharing an example for one of these two pieces of data we're looking at. Okay, so I see one about the patients reporting mistreatment that might ask, why do Black patients in our hospital feel mistreated while receiving maternity care? I think that does a good job of situating the focus on patients in our hospital and what they're seeing and reporting in the data. But it might be, oh, and I see one more coming through the chat. Why does the system more frequently mistreat Black people receiving maternity care than others? So I like that framing because I think you can see the system more explicitly stated. And rather than using the term sort of feeling mistreated, we're accepting the mistreatment is happening. I see, why does our maternity care cause Black patients to experience mistreatment? I think that's a good one too. So again, really shifting on our system being the cause of the outcome. what in our system is leading to mistreatment of Black people more frequently. I think when I was putting this together, I had what aspects of care delivery at our hospital are contributing to higher rates of mistreatment for Black, Hispanic, and multiracial patients. For the first one, I had why are rates of preterm birth in Colorado highest among Pacific Islander people? So looking at what are the rates, where are we situated? Or what in our healthcare system is causing higher rates of preterm birth among Pacific Islander people? All right, well, thanks, Vicki and Amber, for sharing. I also got a few direct messages that I shared aloud, so thanks all of you for your contributions. Really appreciate your thoughts here. So again, that shifting to a systems frame, it can be difficult. I think it's something that takes some practice and takes a bit of getting used to, but helps us focus the question correctly, which makes the tools that Vicki will introduce next a bit easier to use. So I also wanted to emphasize that it's important to focus on why disparities in outcomes exist when you're doing quality improvement with an equity lens. Quality improvement that doesn't focus on equity can result in, you see here sort of three potential outcomes, right? A neutral situation where everybody's outcomes are increased, but we continue to see the same level of disparities. A narrowing situation where everyone's outcomes are increased, but disparities are reduced. And widening, where even if everyone's doing better, in the end, we're seeing higher levels of disparity or inequity among patients. And so ideally, using an equity lens gets us to that middle option, that narrowing. The rising tide lifts all boats, but it also lifts the boats that need it most, the most. And we see this in real life too. Some work in California to decrease C-sections showed a really similar outcome to this first neutral one, where we saw decreased unnecessary C-sections across the state, but we still saw substantial variation across hospitals and across different racial and ethnic groups. So these graphs are hypothetical, but the situation, has happened in many different settings with different kinds of outcomes. So to help target towards that narrowing one, it's really helpful to think about why the difference in outcomes exists when we're talking about quality improvement with an equity lens. And so for this, I'm going to use the C-section example again, because I know it's really relevant to this group. We've seen across the country that C-section rates for non-complex labor have increased. And a root cause I think about all the time as someone who works on payment models is that C-sections are reimbursed at higher rates than vaginal delivery, and they usually progress more quickly, which means there's a system-wide financial incentive to perform C-sections. Now, that's a good observation. It's true. It's something as a healthcare system we could work on fixing, but it doesn't explain the higher rates of C-sections performed on Black and Asian or Pacific Islander patients versus the white or American Indian, Alaska Native patients in Colorado that we saw in the earlier data. It gives us maybe a solution, but not a solution that would address disparities. So you might say, okay, so let's dig deeper into the data and find these hypotheticals that I thought of. You might find out that at your hospital, your Black patients are presenting earlier in labor than people from other racial groups. And earlier presentation is associated with higher rates of C-section. Or you might find that Asian and Pacific Islander people who give birth at your hospital are less likely to have support from a doula or a midwife during birth than people from other racial groups. And we know these supportive birthing partners can be a protective factor against unneeded C-section. So those root causes really drill down into why there might be differences and help give us ideas about interventions that could explicitly focus on reducing racial disparities. So while the first cause is valuable, it doesn't necessarily get at the equity issues we're considering. So I'll leave you with a few additional thoughts for success when using an equity lens for QI. Lean into curiosity and prepare to see racism and other forms of oppression that cause disparities. They may not be an intentional part of the design, but if we see them in the outcomes, they're probably there. Including a variety of perspectives when identifying disparities can be really helpful, and that incorporating patient experience and perspectives in particular is really valuable for identifying root causes and addressing interventions. So I'll pass it to Vicki now, who's going to take a bunch of this foundational stuff I presented to you for a long time, and she's going to share some tools and give you all a chance to practice.
Thanks, Anne. That was a really good grounding in how to shape what the problems are or how we're defining the questions. I also appreciate the framing as a question in terms of like the leaning into curiosity and getting into that space of trying to understand what could be happening on different levels. So let's get into root cause analysis with the health equity lens. Um, I am imagining that many of you have had experiences with conducting root cause analysis, but I assume there's some who are new to it too. So if it's a little bit of a repeat, or you'd like to add some comments from your experiences in the chat, please help add to the discussion. But I am going to try to bring everybody along. So the idea of root cause analysis with an equity lens is to start with the data you have. As Anne covered, it may not be the ideal data, or you may wish you knew more, but you do know a lot from the data that you have, and especially if you've engaged in enhancing your collection of personal demographic data like race, ethnicity, language, social drivers of health, or sexual orientation and gender identity. And you also have patient experience data that you can start with. Then identify the disparity of interest and use the systems framing that Anne talked about. Then bring together the stakeholders. So include the people who are most impacted by the disparity, including patients, families, community members, and the frontline staff who care for those folks. And then you're going to try answering the question that you've developed with the systems frame, and before jumping to potential solutions, you're going to engage in this root cause analysis part by asking deeper questions to figure out what is causing the first things you can think about. So we're kind of referring to that as proximate causes, the ones that are most close at hand, and then deeper root causes. So you may have seen this tool for root cause analysis. This is widely known as a fishbone diagram. There are other names for it too. But essentially, the red box indicates sort of where you start. You put the disparity you're exploring in that red box with that systems framing. And then when you're doing this exercise, there's different ways to do it. You can start by coming up with all of the proximal causes that you can think of, and then choosing the ones most relevant to put in the teal boxes. And then you get into asking yourself why. Why does this proximal cause happen in order to fill in what goes on the arrows? And you can combine it with the tool I'm going to cover on the next slide to get down to the root causes. But some reminders about this. One thing we like about this diagram is that you can expand it and add more, what they call fishbones, I guess, these bigger arrows coming off of the central spine, and add more causes. And you can repeat this exercise with different groups. You can share the findings so far and refine it as you go around talking to different groups about the root causes. So it's a good tool for staying in curiosity mode and trying to refine your understanding of the problem in a holistic way. Sometimes we can have a temptation to move to the solutions that are accessible to us, which is totally normal and natural. If you see a problem and you think, oh, here's what we could do, we could enhance our patient education, for example, because that is right here. We have control over it. We can do it. But the benefit of doing a comprehensive root cause analysis and including all of the things, even the ones you don't have control over, is that it can lead to broader interventions that can have more impact. It can also show you partnership opportunities with other groups who may be focusing on the same issue. And you can be informed by patients and people experiencing your care. And you are not responsible for everything that you identify, which is another nice thing to say at the front when you're starting with these tools. It will be followed by a prioritization process and the QI process in general. So trying something, seeing what the results are, learning from that, and deciding how to go forward. So that can be really nice permission to give yourselves as you engage in this exercise. You don't have to know everything and you don't have to solve everything. But this is trying to develop a holistic view, which can help you to be effective in addressing inequities. So we'll go forward to the 5 whys, which I mentioned is one of the tools. You may also be familiar with this one. This particular example does not have to do with maternity care, but it is one that the Advancing Health Equity Program has developed. So we feel like it's a good one to start talking about the 5 whys as an example. So once you come up with those proximal causes, the idea is that if you ask why 5 times, by 3 or 4, you might get to the root cause, but definitely by 5, you'll be getting to the root cause. So in the example here, the question or problem statement is, why are we less successful keeping our Black children with asthma out of the hospital compared to other children with asthma? And then one proximate cause is we have not adequately helped Black children keep their symptoms under control. Then you keep asking why and figure out we have not adequately taught asthma management. And then continuing on, Black families have reported in focus groups they do not feel comfortable in our clinics, and eventually to the root cause of Black families experience bias in our clinics, and we have very few Black team members, and also our education materials do not speak to Black people's experiences. So that's several different causes, root causes, and you could think about next how to design interventions to address them. So next, we're going to go forward, and I'd like us to engage in a practice question. So we can go and to the next slide. So what we chose for our practice is why has the system been less successful in preventing Black infant mortality based on that data that Anne presented earlier? And we did a little bit of work coming up with the proximal causes that might exist, or more like categories of proximal causes. But we also want to give you all time to think about it. And so Anne's going to take the slides down. I'm going to launch a Zoom whiteboard that we can use. So it should be loading now. You should be able to see something very similar to what was on the slide. And I'll give you a little bit of orientation to Zoom whiteboards. In the bottom right corner, you can see the little hand. You can click on that and then you can sort of move around on the screen. So if it's not centered for you, you can move it around. There's also zoom in and zoom out, which might be helpful as we fill up with post-it notes. So you can sort of navigate using that bottom right hand. And then on the left, you'll see an arrow, a select tool at the top, and that's helpful for picking items. But where you start is really the sticky note, which is right in the middle. So you can click on that and start using a sticky note, choose a color that you like, and then you can type on the sticky note. So that's how we'll engage in this exercise. And what I'd like to do is give you all some time to think through the 5 whys, or at least ask, one why, and start putting in some answers here. Feel free to respond to other people's answers. Put things in the chat if it's too hard to, or just too distracting to use the stickies. And feel free to zoom out and use more of the space on the whiteboard. All right, I see some people are getting us started. So I'm just going to pause and everybody take a little bit of time to think about this and see if you can add a post-it note. One more reminder as you're thinking about this, really try and narrow in. It's good to think of all the causes you can, but ask yourself, is that a cause of the disparity? And really try to focus in on what is causing the disparity in Black infant mortality. So this is a really great start, and you can see how many things really come up that we can always go look for more data also to see, how big, how would we know if this was the biggest cause, or how would we quantify, the contribution of this cause. Um, since you all were so ready for this exercise and had lots of thoughts top of mind, I want to give you a step two, and see if you can pick a post-it and ask another why and get to a deeper root cause for that post-it. And if you can, add the post-it close to it. And we will save this board for your use later. So this might come in handy to you. Something I'm noticing is that I'm seeing a lot about trust and mistrust, kind of in many of the different areas. So this is great. This is a really good start. One that I would highlight that we could take some next steps for example, is this lack of community outreach, the one I see here near community and neighborhood resources. So why is that? Um, and some of the answers you might come up with are we don't have a big enough team, or we don't have a culturally responsive team, or we don't have team members from the community, or we haven't prioritized this. And all of those are potential examples you might come up with and might lead to potential actions you could take. All right, so thank you everybody for contributing. I'm going to move us on for the sake of time, but really appreciate the good start here, and we will make sure you get access to this board. Okay, so going back to the slides. Um, thanks, Anne. I'm seeing the speaker notes. Yep.
Let me try one more time. Sometimes when you close the slides and reopen them, they disagree with you.
Yep. Yeah.
Here we go.
So the times that I have done root cause analysis with clinical care teams, some of the things that I think have been really helpful are being really precise in the question. So certainly having data that you're working from, as we've already set up here, and bringing the right people to the room, or being willing to repeat the exercise multiple times until you can feel like you have a really good holistic picture. And encouraging everybody who's present to stay in the curiosity mode, thinking through, we're just coming up with ideas here. We will fact check them. We will look for our data. We will come up with how to address these root causes next. So here's some additional resources on conducting a root cause analysis. The Advancing Health Equity program I mentioned before has a curriculum on diagnosing root causes and prioritizing root causes. AHRQ also has using root cause analysis to improve quality and performance, and CMS has an RCA with PIPs and how to use the fishbone tool and a 5 whys tool for root cause analysis. So briefly, I want to mention what comes after a root cause analysis. So what we have done with teams is start to make a list or a collection of some kind of potential actions that you could take to address that root cause. And in many cases, it's easy to come up with what someone else should do. Um, but it's a little harder to think through what is my role in that, or what could I do in that. And maybe your role isn't as direct. Maybe it is someone else's job to do something for a root cause, but maybe your role is something a little less direct or closer to the end of something someone else has to do. So coming up with what it is you can do is really important for thinking through who your team is and how you can address the root causes. And then we recommend using a chart like this. Across the top is feasibility, and then down the side is health equity impact. So the idea is that you think about all the potential actions you might take, and you think about how feasible is this and what is the level of impact I expect. And you'll get some things that are very feasible, very easy to do, but might have a smaller health equity impact, and some things that have greater health equity impact. And then you'll also think of things that would have a really big impact, but it's not feasible because you don't have the data exchange systems you would need, or you have to build a relationship first, or there's other things to do in the interim. It's important to record all of this. Because say you do get that data system, then that would move something from the less feasible column to the more feasible column. And you would have something you could motivate your team around without redoing a root cause analysis necessarily. So the idea then would be to pick a few things in the more feasible, greater health equity impact column, the low-hanging fruit, so to speak, or the things you can immediately address, and put those into your PIPs, start doing interventions, start talking about your work and bringing people along, and measure the impacts. Okay. We want to cover a couple of additional tools, really just one. It's the four corners exercise, which Amber brought to our attention. So as a brief overview, this is really about trying to bring together the right people also to understand a topic or question that you have. So trying to see other points of view, considering the challenge from multiple perspectives, and thinking about the problem-solving strengths of different team members and the different positions that people have from seeing the problem. So on the next slide, we have an example from CPCQC from their Spark initiative. And this is specifically about how might we ensure all patients are scheduled for a postpartum visit before hospital discharge. And you can see the four main perspectives included here are the OB provider, the postpartum nurse, the outpatient office, and the patient. And I'll hand it over to Amber in case there's anything you'd like to highlight about this initiative.
Yeah, thanks, Vicki. This is a common challenge that our hospital teams face, which is trying to get patients scheduled for their 2-week postpartum visit prior to hospital discharge. And we know that gaps in postpartum care are a contributor to maternal mortality. So something that our hospital teams want to do better. And one of the approaches that we've recommended for them is to find out where the system is breaking down from a variety of perspectives. And so like Vicki said here, it was very interesting to hear from these different perspectives, their different takes on solutions, particularly involving the patient's perspective, which I think probably, if we were weighing the potential input, the patient probably should have an outsized input on the solutions. And this was able to support the hospital team to try a couple of new processes, right? And so do those plan, do, study, act cycles of let's try a change, let's see if this increased our postpartum visit attendance, and then let's move on. And so again, I won't read the slide to you, but an interesting exercise anytime you're facing a quality improvement problem that seems insurmountable. I think the fishbone diagram, the 5 whys, the 4 corners, I think all do a great job about breaking down really big, hard problems into more digestible or solution-oriented steps.
Thanks, Amber. One thing I really appreciate about that example is that you can see how text messages pops up in multiple boxes, and that might I don't know if it's already done or not, but that might help strengthen the case for doing it. So it makes sense. Okay, we have a couple of takeaways that we want to summarize, and then we're going to have plenty of time for questions. Um, so here are the takeaways from today's presentation. We started at data, disaggregate outcomes, process, and experience of care data by race, ethnicity, language, and other data in order to find disparities. So we know that overall outcomes are good in Colorado, but that could be masking some disparities and some opportunities to close gaps. So that's where we recommend you start. And then we've talked a lot about this mind frame of leaning into curiosity, seeking that systemic understanding, assuming that oppression shows up in your systems, even if it wasn't the intention of whomever has designed the systems. And even if you're very careful about how you provide your care, it is larger than all of us. Um, and then we talked through framing QI questions from a systems perspective and focusing on the difference in outcomes in order to be health equity focused when doing QI projects. And then we went through the use of QI tools like the RCA, 5 Whys, 4 Corners, and there's plenty of others out there as well to diagnose root causes and prioritize interventions. And then, we separated the dreaming up interventions from the prioritizing of interventions. We also recommend recording reasons why certain things might not be done. You never know when that might be useful. Come budgeting season or when things change in the future, you get a new CMO, who knows what happens. If you have recorded the things you would want to do in different circumstances, then you have those to go back to. So here I'd like to pause and see what questions or thoughts are coming to mind for you all. And if you have any other QI efforts you want to mention to the group, we welcome that too.